factor to influence in this link. We will then point out the only in leptin hypothesis for the time. It's a novel hypothesis is emerging of the role of leptin in pathogenesis of asthma. Even after controlling body mass index, leptin was known to be increased in asthmatic patients. And in patients who is obese with obstructive apnea, they exhibit increase in leptin levels and approximately 50%. It's postulated that OSA may lead to leptin resistance. This is important because the increased level may result for hypoxia stimulus, but at the moment the exact mechanisms is not yet understood. Therefore, the relation between elevated level leptin and OSA patient and asthma probably lead the relationship between those diseases. We are talking about how OSA makes worse asthma, but what happens if we think backwards? The idea now is why asthma may worse OSA. We are talking about obesity, we are talking about probably nocturnal hypoxemia associated with respiratory event, influencing this can worse OSA. Poor sleep quality could predispose to increased upper airway collapsibility and lower arousal threshold, leading to ventilatory instability and respiratory events. We are talking, the doctor president was talking about the nasal congestion, and nasal congestion increase the nasal resistance and increase the negative pressure in upper airway during inspiration. This also has been shown a significant reduction in upper airway dimension during inspiration and expiration in patients with asthma. It is known that the sleep may contribute to bronchospasm as a result of frozen lung state, which can occur when active amniotic cross-bridging become strong. And we know that deep inspiration is a potential bronchodilator and has the capacity to disrupt these breaches and prevent bronchoreactivity. It's known that nocturnal asthma may be due to lack of deep inspiration. Patient obstructive apnea may contribute to this, since there is no stretch during obstructive apnea. Finally, asthma, obesity, and sleep apnea, obesity, asthma, and sleep apnea, are characterized by low-grade inflammation and oxidative stress. It can also cause a lot of changes in sleep-associated homeostatic control of airway function and ventilation. They share a similar genetic susceptibility. What is our conclusion? We believe that sleep disorder breathing and obstructive pulmonary disease are detrimental each other. CPAP could be improved asthma symptoms. Local and systemic inflammation exists in both conditions. We believe that it's necessary to increase research to look interaction between the upper and lower airway with SDV. It's necessary to understand how interaction between local systemic inflammation and oxidative stress pathways can influence on sleep disorders in SDV and obstructive pulmonary disease. And finally, we need urgent guidance approach for screening both conditions, how the treatment has influence from one disorder to each other. Thank you very much for your attention. I would like to invite to visit my beautiful city.
Thank you, Ivan, for your really complete presentation that emphasized this, the relationship among several respiratory diseases, and also a lot of doubts that we have in this field concerning the approach, the pathogenesis, and especially the role of inflammation that we don't know really if it is the cause or is the effects of some of the aspects that you have mentioned. Question from the audience? Glenis. No.
Do you know whether OSA is more associated with neutrophilic asthma or with eosinophilic asthma?
Yeah, there is only one study that was made for Levin from Europe, from France. they found it's not a correct explication why there is increased neutrophil in obstructive apnea, but probably depend of what kind of asthma, because there is a asthma who have more neutrophils than the eosinophil. The idea is what's the matter with this kind of patient. He responds more with CPAP than the other, but now it's not exactly a mechanism to explain.
Okay, and can I ask another one?
First,
We know that asthma is often associated with upper respiratory tract changes,
Exactly.
rhinitis in the milder and rhinosinusitis in the more severe. Do you think it's possible to differentiate between what is contributing to the OSA? Is it the asthma, or is it what's going on higher up?
I believe that it's upper airway who contribute to lower airway, because it's more frequently to find patients with allergic rhinitis or alteration in upper airway. But the problem is the mechanisms. We believe that is an increase of cytokine and chemokine who influence in lower airway. I believe that is a new research in the future, for example, to what is the utility to make oropharyngeal exercise, because there is a study where we use oropharyngeal exercise in moderate obstructive asthma is possible to decrease apnea-hypopnea index. And the idea is, if I have patient, we have alteration in upper airway, and why don't they use the oropharyngeal exercise before to use CPAP, before to use a dental device or surgery?
Thank you very much.
Thank you.
Thanks very much. So